years ago. Which brings us to the question of when to do a transplant. This is a very complex decision because nowadays, as you know, there are many good alternatives to transplant for a period of time. So for many patients, my sense of myeloma for most of the patients I've met is that at some point in the course of their disease, they are going to need a transplant. Almost irrespective of age, type of myeloma, stage of disease, and so on. Almost, not always, but almost all patients will or may need a transplant at some time in the course of their treatment. Whether patients should get this early upfront as an alternative to other treatments a little bit later on or so on, that's a much more individualized decision which is not possible to make in a large forum. But I think transplant should be considered. At least the question should be asked at some point during the treatment. For many patients, the answer is going to be no, not now, or perhaps never. But at some point, the question should be asked. The evidence we have now suggests that an early transplant may have some advantages compared to a late transplant, partly because it may be better when there is less disease or less chemotherapy refractory disease. It may provide a break in time from other treatments. So this is the type of treatment where one of my clinics right now is in far in the West Valley, where some individuals spend only part of their year here and part of it somewhere else. This is the type of treatment where somebody can get a transplant within 100 days or so, probably be well enough to then go back where they like to live the rest of the year and be free of treatments until they come back again. It can be repeated. We talked about age is not as important as previously thought. Some treatments can make a subsequent transplant more difficult, so it's always important to ask this question early. If you are a patient who might need a transplant, it's important to know that early on with treatment. What's the future of transplant? Well, we need to do better with finding out when is the best time to do a transplant, who will benefit the most and who might not, how to modify the drug treatments and make them more effective, and how to reduce the side effects. Although the side effects are finite, yet for that 2-week period, they are very significant for most patients, and if we can reduce that, that's even better. Now, another type of transplant. So imagine that when you went to get the grass seed to replant the lawn, instead of taking seed from the same stock as your previous grass, this time you went and got an improved seed, which itself has some anti-weed activity. In other words, it has some activity against the weeds that could come up. That is what we try to do when we use someone else's bone marrow cells to replace a patient's after transplant. We're basically trying to harness cells from someone else who has never had myeloma and therefore might have cells that would have some immune activity against myeloma cells. Currently, the state of the art is that if you have a sibling who is matched and you're fairly young, this might be a good treatment to have early on. I suspect that as time goes on and as this treatment gets better refined, it may be able to be extended to more people, especially as we expand the donor pool of unrelated donors, and also with a source of bone marrow cells that comes from umbilical cord blood, which would otherwise have been discarded after birth. That might likely increase the number of patients because not everybody has a matched sibling donor. And then, of course, healthcare costs and access. This is a graph that I thought I would show quickly in conclusion, where one of the early trials in which they tried to compare patients who would get a double transplant using their own stem cells versus those patients who, because they had a sibling who happens to be matched genetically to them, which happens 1 in 4 for every full sibling. Because they had that, they then got one transplant from their own cells and then a subsequent transplant using stem cells taken from that healthy sibling. And they compared the two graphs. So where you see 2 lines, that is a comparison by time. And it's hard to show with the pointer, but perhaps this one graph, you see that with the patients labeled as autograft followed by allograft, which are the patients who got one autologous transplant from themselves, followed by a transplant with stem cells harvested from a sibling, that it did appear as if a time came when if you had not relapsed, then you would not relapse, at least for the duration of observation of the study. It's a very preliminary study, but it gives us a glimmer of hope that if we can extend this technology to more individuals, either by making it safer so more individuals can get transplants from non-siblings, or making it safer so this can be extended to older individuals or to patients who have more side effects and so on, and still be able to do it, that might be a way that patients can finally start looking at a treatment for multiple myeloma, which may possibly be able to be given once and then curing the patient so that they don't have to have repeated treatments. And we really hope that type of treatment can be extended. So that's a short summary of bone marrow transplant, stem cell transplant, and how it's applied to myeloma. I think I'll reserve questions for when we have a panel discussion, if that's okay. Thank you very much.